Sorry. Alrighty. So today we'll be talking about some more advanced topics in ADHD psychopharmacology. And because I'll be focused on psychopharmacology today, I want the pharmacist to take it easy on me. I started going through the details of the different ADHD medications, and it really ended up based on the amount of information and detail. I could only get through sort of the stimulants and a little bit on atomoxetine, and we can continue if there are questions on guanfacine and clonidine. And some of this might be review for some people. Some of it might be review, but I'm hoping some of the details will be helpful as folks try to manage some more of the subtleties of ADHD. And because this is focused on psychopharmacology, and we've talked about ADHD before, I'm not going to go over the diagnostic criteria. We all know, right? There are three subtypes, or sometimes people call them sort of three different presentations of ADHD. You have the hyperactive impulsive type, the inattentive type, and the combined type. So let's start off with the treatment, focusing on stimulants. And again, big picture, right? Two categories of stimulants: methamphetamines and methylphenidate and amphetamine. So methylphenidate and amphetamine, and both are available in either the single dextroisomer or in the racemic version that has both the D and L isomers. And what's interesting is you'll hear about different kinds of data on how successfully ADHD can be treated. There's a 1991 study that showed if you successfully switch between stimulant classes. So in other words, you start off, and this study in particular looked at dextroamphetamine and methylphenidate. And the non-response rate before doing this switch was around 32%. In other words, if somebody presents with ADHD, meets criteria for ADHD, and is treated with one stimulant type, the treatment response rate is around 70%. In other words, non-response rate around 30%. But then when given the opportunity to switch to a different stimulant class, so between, again, the amphetamine family and the methylphenidate family, the non-response rate dropped to 4%. Now, one caveat with this is the following. I think in clinical practice, the non-response rate is probably a lot higher than 4%. So a couple of issues with that data. So first of all, there you were looking at mostly folks with very few comorbidities. And so in a real life situation, you get somebody with multiple comorbidities, and about 2/3 of patients with ADHD present with comorbid psychiatric disorders like depression or anxiety. Again, 2/3. So you're going to be getting most likely people with comorbidities. So the response rate is probably not going to be as high. And the other thing is, in these studies, they often don't include placebos, so the actual stimulant response rate might be closer to about 55%. In other words, placebo. There is some placebo effect in treating ADHD, much smaller than SSRIs or other psychiatric medications, but still, we can't discount the existence of a placebo response. So anyway, big picture, the actual stimulant response rate is definitely greater than 50%, but certainly not as high as 96%. But bottom line is, combining different stimulant classes will get you a better response rate. So starting with methylphenidate, so it's the active ingredient of the majority of stimulant prescriptions in the United States, and has a large effect size. And actually, the effect size for methylphenidate and stimulants in general, by the way. So the difference between methylphenidate and amphetamines, there's no significant difference in terms of the benefits when treating ADHD. And if you do get someone with ADHD, meets criteria, minimal comorbidities, the effect size of 0.91 is rather large, and I think approximates that of antibiotics. You have rapid absorption, and you get effects within 30 minutes with a 3 to 5 hour duration of action. And you get a peak plasma concentration by 90 minutes. So again, methylphenidate, you get rapid absorption, effects within 30 minutes, and 3 to 5 hour duration of action. So dexmethylphenidate, the brand name Focalin, the D3 enantiomer of racemic methylphenidate. And important to keep in mind, this is sort of the one that's more active. So D is more active than the L. And so that's why this one is used in Focalin. And similarly, you get a plasma concentration that increases rapidly right after ingestion. And the maximum concentration is about 1 to 1.5 hours after taking the medication. So the long-acting ones, they're in general. So again, So if you bear with me, so methylphenidate, you have the immediate release, and then you have long-acting. But within long-acting, think about 3 different categories. One is a single pulse, another one is a dual pulse, and then the third is really a slow release, and it's designed to sort of mimic what it would be like to take 3 doses of Ritalin or methylphenidate. So again, you have immediate release methylphenidate and then 3 categories of long-acting methylphenidate. So the older sort of single pulse long-acting methylphenidate is sort of, and the name brands are Metadate ER and Methylin ER. It's sort of this wax matrix preparation that's designed to prolong release. So now the thing is, the other medications have immediate release wrapped around the core of a long-acting mix. These do not. So in other words, so it's like stuck in this wax matrix, and so it has a slower onset of action than immediate release, and ultimately lower serum concentrations. This type of long-acting methylphenidate, so Metadate ER, Methylin ER, has a 6 to 8 hour duration, and so therefore you might see in certain situations folks who prescribe this with immediate release at the same time to compensate because it's slower to act. In other words, you're not going to get a 30-minute response like you do in immediate release. So the next one, so remember I said there's sort of single pulse, now there's dual pulse, and these are the 3. There's Metadate CD, Ritalin LA, and Focalin XR. And these are similar in that they're beaded methylphenidate products using this SODAS, which is spheroidal oral drug absorption system. But basically, it's a capsule with a mix of immediate release and delayed release beads. So essentially, it's like if you look at Ritalin LA, again, which is a combination of these beads, you're mimicking giving immediate release methylphenidate in 2 doses about 4 hours apart. And Focalin XR uses the same sort of technology. So again, this is your dual pulse release. Then the third type is Oros, which is an osmotic delivery system, right? Well, this is the Concerta. It sort of simulates a triple pulse. In other words, the amount of medication and duration of action simulates giving Ritalin TID. And so if this works properly, it can reduce ADHD symptoms for up to 12 hours. And this is a situation where the immediate release methylphenidate is actually applied to the outside of that core osmotic release system. So you get immediate access to the methylphenidate. So for Concerta and good generic Concerta, you will get onset of action within 30 minutes, and then you have the osmotic release system that's left over. And you'll get this sort of slightly ascending MPH serum concentration curve. And sorry, this is something I guess I already said. Oros MPH it mimics serum concentration produced by taking immediate release methylphenidate. Next, looking at the amphetamines. So 2 types, right? You have the racemic, which is sort of the mixed amphetamine salts, or Adderall and Adderall XR. And then you have the one with the 1 isomer, the dextroisomer. So there's dextroamphetamine, which is dexedrine, then lisdexamphetamine, which is Vyvanse. For amphetamine, the plasma levels peak about 3 hours after PO administration. And what's important to keep in mind that acidification of the urine actually increases urinary output. So in other words, if you have a patient who takes Adderall with fruit juice and you're not getting the benefits that you would expect, see if you can tell them not to do that, right? So giving fruit with fruit juices will actually decrease the absorption and thus decrease the benefit of having Adderall. For amphetamine salts, the effects can be seen within 1 hour of ingestion, and duration of action is up to 5 hours. So this is something there's something to remember. So if there aren't a ton of differences between methylphenidate and amphetamines, but one is certainly duration of action. So in general, amphetamine salts will last longer in terms of the duration of action than methylphenidate. So in sort of you'll see at the end here the table, but if you look at tables that describe sort of onset of action, you see methylphenidate is indicated to last 3 to 5 hours, and amphetamine salts 4 to 6 hours, so just slightly longer. So long-acting amphetamine, there's Adderall XR, which is that, as I mentioned before, so the capsule preparation of immediate release and extended release beads. And again, what's nice about these beads, by the way, and you've probably all sort of done this, I imagine, is if a child can't take a capsule or a pill, you can open up these beads and put them into applesauce. And again, what's happening is they're getting all the beads. They're getting the immediate release and the extended release beads, so no problem. Lisdexamphetamine or Vyvanse is inactive parenterally. And the way it works is you have D-amphetamine that's covalently bonded to L-lysine. And so that bond is cleaved during digestion, and that then turns into the active product. And the treatment effects can last up to 12 hours. So, the digesting process and the release of the active amphetamine isomer can lead to benefits for up to 12 hours. And so this is a summary table. So I'm just going to show you the summary tables real quick, and then we'll talk about some side effects and adverse events with these medications. So again, methylphenidate at the top there, right, 3 to 5 hours, and then you have the starting dose and typical doses. Dexmethylphenidate or Focalin, you'll see the dose is half of that. Again, it's twice as strong, so that's why you have sort of half the dose. Metadate ER, you got your single pulse, then you have Metadate CD, your dual pulse, and then the Oros MPH, the ascending single pulse, again, which sort of mimics a triple pulse. And then you have the starting doses and typical doses. And then the summary table for amphetamine salts, right at the top you have amphetamine salts, duration of action 4 to 6 hours, and starting dose and typical dose. Dextroamphetamine or dexedrine, then you have Adderall, which is the dual pulse, and then lisdexamphetamine, which is the prodrug. And so really no pulse to be, I suppose you could say it's a one long single pulse, but really what's happening is that the GI tract is digesting this and then cleaving the active product into the circulation. So some more information about stimulants and side effects or adverse events. So, one of the things that is can be concerning is, and it's a real thing when some kids you can see increased sort of tics in kids who are taking stimulants. It's certainly one of the side effects that's sometimes discussed. But in general, right? So that's sort of the one-off person that you see. But in general, there was a pretty extensive study. It was done in 1995, and it was a controlled trial that involved kids with ADHD and chronic tic disorders taking methylphenidate, and they showed a significant improvement in ADHD symptoms without consistent worsening or increase in tic frequency for all the subjects. The one caveat is the overall dose of methylphenidate in this study was actually just a little bit lower than you see in that table. So I think instead of going up to 30 milligrams in a day, I think they only got up to like 20 milligrams. But in general, you can, although there is that concern, there's no need to stay away from stimulants in kids who have tics. Stimulants anxiety, and you may have heard me say this before. There was a thought, I think like 20 years ago, there were concerns about stimulants and increased anxiety, and I think there may have been sort of warnings to that effect. But a study showed in 1995, and actually it was the same study as one I just quoted, actually. It's the same study. So 1995 controlled study tested methylphenidate on youth with comorbid anxiety symptoms. And they actually showed equally good response in youth for with or without anxiety. And then a different study was a meta-analysis of 23 studies that showed that looked at almost 3,000 youth with ADHD, found that stimulant treatment actually reduced the risk for anxiety versus placebo. And so, and the idea I think, again, there's no sort of anxiolytic property to the stimulant. But the idea is that some kids with ADHD, who number one are vulnerable to anxiety anyway, may have sort of underlying mild to moderate anxiety, may have their anxiety exacerbated by feeling overwhelmed by the ADHD symptoms. In other words, if these kids go to school, have information coming at them at a pace that might be overwhelming them because of their ADHD, you add the stimulant, now their symptoms are a little bit under control, they don't get easily overwhelmed, and their anxiety is reduced. And I've seen this with depression as well. I've seen some kids who come in with ADHD and depression, and something similar where they start feeling overwhelmed, they feel bad about themselves. You improve their ADHD symptoms, and now their self-esteem starts to improve a little bit because they're not feeling as overwhelmed and at a disadvantage all the time. Stimulants and adverse events. There's a 2005 FDA review that reported 135 adverse event reports for Oros MPH, or methylphenidate, which is the Concerta, out of 1.3 million cases. And so, again, they did pick out sort of the adverse events that were concerning them, right? There were 36 psychiatric adverse events that included 12 instances of tactile and visual hallucinations. So, you might hear people talking about the concerns, but if you look at this, this rate is pretty small, right? 12 out of 1.3 million with tactile and visual hallucinations. And then out of those 1.3 million, there were 20 cardiovascular events. And again, in stimulants, the biggest concern are sort of sudden death from a significant cardiac event. But again, these are incredibly rare, and there's no need to be doing EKGs or sort of very close sort of cardiac monitoring unless there's a family history of sudden cardiac death and significant cardiac comorbidities. ACAP, the American Academy of Child and Adolescent Psychiatry, had a work group on quality issues. The rate of sudden unexpected death is about 0.5 per 100,000 patient years for those taking mixed salt amphetamines, and 0.19 per 100,000 patient years for methylphenidate. Interestingly, if you look at the general population, the rate is 1.3 to 1.6 per 100,000 patient years. So in other words, if you look at the big picture, there's no significant increase in a rate of unexpected death because of taking the stimulants. But they still require monitoring, of course. Then sort of lastly here, just a quick comment on atomoxetine or Strattera. Right, it's a selective norepinephrine reuptake inhibitor. It's the first drug that was approved by the FDA to treat ADHD in both youth and adults. And in several treatment algorithms, most notably the Texas Medication Algorithm Project, which looks at algorithms for mental health in youth, they use atomoxetine as a second line to stimulants. The effect size for this and other ADHD medications is sort of medium, which is 0.64 here. And again, I